The learning objectives for mastering the abdominal examination are to inspect for symmetry, scars, and striae, to auscultate the bowel sounds, to percuss the liver, to measure the liver span, perform light and deep palpation, and to palpate the liver edge, to examine the spleen, and to assess the costovertebral angle tenderness. The common or the concerning symptoms of the gastrointestinal tract are indigestion, nausea, vomiting and hematemesis, abdominal pain, dysphagia and odinophagia, change in bowel function, constipation or diarrhea, and jaundice.
Good evening, madam.
May I know your name and age, please?
My name is Snithu Reddy. My age is 50 years.
Okay. What is your reason for your visit today?
Just abdominal examination, madam.
Do you feel like any abdominal pain?
No,
Vomiting and diarrhea?
no, madam.
Do you feel nausea?
No, madam.
Do you feel constipated?
No, madam.
Okay. Now I'll proceed with your abdominal examination. Is it okay for you?
Okay, thank you.
The wall extends from the rib cage above to the pelvis and inguinal ligaments below. The rectus abdominis muscle can be identified when the patient raises both head and shoulders from the supine position. Palpation is easier lateral to these muscles. The abdomen is divided by imaginary lines that cross at the umbilicus. These lines form the right upper, right lower, and left lower quadrants. Also, the abdomen is divided into 9 regions. The 3 midline regions are the epigastric region, the umbilical region, and the hypogastric region. Before you examine the abdomen, make sure that the patient has emptied his bladder. Lower the table flat and ask the patient to lie down and relax. Expose the patient's supine's lower abdomen by raising the gown below the nipple line and lowering the drape to the suprapubic level. Then, inspect the skin for scars, striae, dilated veins, rashes or ecchymosis. Also inspect the symmetry and contour of the abdomen. Note if it is flat, rounded, protuberant or markedly concave or hollowed or there are any bulges. Observe the contour of the umbilicus to look for the signs of inflammation or hernias or peristalsis or aortic pulsations visible in the epigastrium. Warm your hands and your stethoscope and listen for bowel sounds by placing the diaphragm of the stethoscope gently over each quadrant. Listen to the abdomen before performing percussion because these maneuvers may alter the frequency of bowel sounds. Occasionally, you may hear the normal stomach growling. If the patient has high blood pressure or atherosclerotic disease, listen in the epigastrium over the aorta and then listen over the iliac arteries and the femoral arteries. Next, lightly percuss the abdomen to assess the distribution of tympani and dullness. Tympani is a high-pitched musical sound that indicates a hollow space filled by air or gas in the stomach or the intestine. Dullness suggests fluid or underlying organs like the liver and spleen. Now, palpate the 4 quadrants of the abdomen for tenderness, beginning gently and saving painful areas for the last. With your fingers together, place your hand flat on the abdomen and press using a light dipping motion. Moving smoothly, palpate all quadrants, identifying any tenderness or increased resistance to your hand. Observe the patient's face closely for indication of tenderness or discomfort. If the abdominal muscles are tense, try to relax the patient and palpate gently again. Having the patient flex the knees is often helpful. Then palpate by focusing more deeply in all 4 quadrants as you feel for any masses or tenderness. Placing one hand on top of the other, watch closely for the signs of an acute abdomen from inflammation of the parietal peritoneum or peritonitis. Percuss the span of the liver, first locate the midclavicular line. Use a light to moderate percussion strike. Starting at the level below the umbilicus in the right lower quadrant in an area of tympani. Percuss up toward the liver, identify the lower border of dullness in the midclavicular line. Next, identify the upper border of the dullness starting at the nipple line. Lightly percuss from the lung resonance down toward the liver dullness. Measure the span of liver dullness, which is usually 6 to 12 centimeters in the right midclavicular line. To palpate the liver, place your left hand behind the lower thorax, lifting up the 11th and 12th ribs, overlying soft tissues. Place your right hand just below the right upper quadrant, lateral to the rectus abdominis muscles, and well below the lower border of liver dullness. Ask the patient to breathe deeply. Press gently into the abdomen and ask the patient to breathe deeply. Try to feel for the liver edge as it moves down to meet your fingertips. If possible, let the liver slip under your finger pads as you feel its anterior surface. You often need to try again, moving your fingertips closer to the costal margin. The hooking technique may also be helpful. Standing to the right of the patient's chest, place the fingers of both hands below the border of liver dullness and press in and up towards the costal margin. To assess for tenderness, when the liver is not palpable, place your left hand flat on the right lower rib cage and gently strike it with the ulnar surface of your right hand fist. Ask the patient to compare the sensation to the other side. To palpate the spleen, to assess its size, reach over and round the patient with your left hand to support the left lower posterior rib cage and overlying structures. Place your right hand below the left costal margin and press it with your fingers towards the spleen. When the patients take a deep breath, feel the spleen as it comes down to meet your fingertips. The tip of the spleen is palpable only in 5% of the normal adults. Alternatively, ask the patient to turn onto the right side with the legs somewhat flexed at the hips. In this position, gravity may bring the spleen forward and to the right into a palpable location. To help detect splenomegaly and enlarged spleen, percuss the left lower anterior chest wall roughly from the border of the cardiac dullness at the 6th rib to anterior axillary line and down to the costal margin. This is an area called drop space. As you percuss along its route, note the lateral extent of tympani. If tympani is prominent, especially laterally, splenomegaly is not likely. Then ask the patient to take a deep breath and percuss again. When the spleen size is normal, then percussion note usually remains tympanic. When spleen is enlarged, tympani often changes to dullness. To palpate the left kidney, move to the patient's left side and place your right hand just below and parallel to the right 12th rib with your fingertips just reaching the costovertebral angle. Lift trying to displace the left kidney anteriorly. Place your left hand gently in the left upper quadrant, lateral and parallel to the rectus abdominis muscle. Now ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply into the left upper quadrant just below the costal margin and try to capture the kidney between your hands. If kidney is palpable, assess its size, contour and any tenderness. To capture the patient's right kidney, return to the patient's right side and use your left hand to lift up from the back and your right hand to feel deep in the right upper quadrant. Proceed as before. Normally, the right kidney is palpable when the patient is thin and abdominal muscles are relaxed. To assess the aorta, press the upper abdomen slightly left of midline and feel for aortic pulsations. Now try to assess the width of the aorta, especially in the older smokers at risk for abdominal aortic aneurysm. Pressing gently on each side of the aorta, try to estimate its width. Normally it should be less than 3 centimeters. Next, ask the patient to sit up and assess for costovertebral angle tenderness seen in pyelonephritis. Place the ball of your left hand on each costovertebral angle in turn and strike it with the ulnar surface of your fist. Normally, there is no tenderness over the normal kidneys.